Central cannulation is most often used in the immediate post-operative setting when the chest is already open. Direct access to the right atrium for venous drainage and the ascending aorta for arterial return allows the circuit to deliver excellent flows, sufficient even for the smallest neonates. Because blood is returned centrally, there is no risk of limb ischemia, which can be a complication with peripheral cannulation. For post-surgical patients who fail to separate from bypass, this approach provides immediate access to initiate support without additional incisions. The disadvantages reflect the open chest requirement. An exposed mediastinum increases the risk of bleeding and infection, both of which carry significant morbidity. Prolonged open chest management also delays mobilization and complicates post-operative care. Once ECMO is discontinued, operative closure is required, which adds another procedure to the infant's course. At the bedside, central cannulation demands meticulous infection control, close surveillance for hemorrhage, and coordinated planning with the surgical team for eventual chest closure. Although invasive, it provides the most reliable flows and is often life-saving in neonates who cannot be stabilized by peripheral access. Peripheral cannulation is an alternative to central access and is most often performed in the neck. In this approach, venous drainage is established through the internal jugular vein and arterial return through the carotid artery. The main advantages are the ability to close the chest, which reduces infection risk and improves wound management, and the potential for better mobility and positioning of the infant compared with an open sternum. The trade-offs are significant. Ligation of the carotid artery carries a measurable risk of stroke or other neurologic complications, especially in preterm or critically ill neonates. Vascular compromise in the cannulated region is another concern. For groin cannulation, the femoral vein and artery can be used, although this technique is less common in neonates because vessel size limits achievable flows and increases the risk of limb ischemia. From a practical standpoint, peripheral cannulation can be life-saving when immediate central access is not available or when maintaining a closed chest is desirable. At the bedside, clinicians must carefully monitor for neurologic changes, vascular compromise, and adequacy of flows, as these risks are more pronounced than with central cannulation. In extracorporeal membrane oxygenation, the type of cannula and its placement define the type of support provided. Veno-venous ECMO typically uses a dual-lumen cannula, most often placed in the right internal jugular vein. This design allows drainage and reinfusion through separate ports within the same cannula, supporting oxygenation and carbon dioxide removal without contributing to cardiac output. Veno-arterial ECMO, by contrast, requires separate venous and arterial access, commonly a right atrial venous cannula and carotid arterial return. This configuration provides both gas exchange and circulatory support, making it essential for patients with myocardial dysfunction, but also carrying greater risks, including vascular compromise, carotid artery injury, and neurologic sequelae. Cannula size must be carefully chosen to achieve adequate flows while minimizing vessel trauma, with larger infants tolerating larger cannulas. Correct positioning is confirmed by echocardiography or radiography to ensure optimal drainage and return, reduce recirculation, and maintain effective support. Secure fixation at the skin level is equally critical, as even minor migration can compromise ECMO efficiency or cause life-threatening complications. Safe and effective ECMO management depends on continuous hemodynamic monitoring within the circuit. Flow rate is the cornerstone parameter. For neonates, the goal is 100 to 150 milliliters per kilogram per minute, which typically provides full systemic support. Lower flows may be adequate if the infant retains meaningful native cardiac output, but inadequate flows risk tissue hypoxia. Venous pressure reflects adequacy of drainage. It should remain slightly negative, indicating that blood is being withdrawn efficiently from the right atrium or great veins. If venous pressure rises, cannula position or intravascular volume must be reassessed, as poor drainage can rapidly compromise support. Arterial pressure is monitored after the oxygenator, representing the pressure with which oxygenated blood is delivered back to the infant. This helps identify excessive afterload on the pump or obstruction downstream in the cannula or circuit. Transmembrane pressure is the gradient across the oxygenator. A gradual increase over time suggests clot deposition or membrane failure, both of which limit gas exchange and increase hemolysis risk. Closely related is delta pressure, which describes the pressure drop across circuit components. Significant changes in delta pressure can signal clot formation, kinking, or component malfunction. For the bedside team, interpreting these parameters together allows early detection of problems. Declining flows, rising venous pressure, or increasing transmembrane gradients all provide warning signs that require immediate evaluation to prevent catastrophic circuit failure. Oxygenation and perfusion monitoring ensures that ECMO support meets the infant's metabolic demands. Pre-oxygenator blood gases represent venous blood returning from the patient and reflect adequacy of systemic oxygen extraction. Persistently low pre-oxygenator saturations may indicate inadequate flow or excessive oxygen consumption. Post-oxygenator blood gases measure circuit performance. A high post-oxygenator oxygen content confirms that the membrane is functioning. A falling gradient between pre- and post-oxygenator samples can suggest oxygenator failure or clot formation. Mixed venous saturation, typically sampled from the venous limb of the circuit, is an important global indicator of tissue oxygen delivery. Values in the normal range suggest balance between oxygen delivery and consumption, while persistent desaturation indicates inadequate support or outgoing shock physiology. Arterial blood gases obtained from the patient provide the final confirmation of systemic oxygenation. These values account for the mixing of ECMO flow with native cardiac output and are the most clinically relevant to tissue perfusion. Lactate levels offer another window into tissue health. Rising lactate indicates impaired perfusion or anaerobic metabolism, even when oxygen saturations appear normal. Near-infrared spectroscopy adds regional data, particularly for cerebral oxygenation, and helps detect early changes in brain perfusion. At the bedside, integrating all these parameters is critical. Circuit values show whether ECMO is performing properly, while systemic and metabolic measures confirm whether tissues are receiving adequate oxygen and nutrients. Together, they guide timely adjustments to flow, sweep, and ventilator support. Systemic anticoagulation is required immediately after initiation of ECMO to prevent clot formation within the circuit. Unfractionated heparin is most commonly used. Activated clotting time, or ACT, is the traditional bedside test, with a typical target of 180 to 220 seconds, although exact ranges vary by institution. Partial thromboplastin time provides an additional measure of anticoagulation, with many centers targeting 60 to 80 seconds. Some programs prefer anti-factor XA levels, which correlate more directly with heparin activity and may provide a more precise assessment than ACT or PTT alone. Balancing bleeding and clotting remains a constant challenge. Too little anticoagulation risks circuit thrombosis and embolic events, while excessive anticoagulation leads to surgical site bleeding, pulmonary hemorrhage, or intracranial hemorrhage. The circuit should be inspected frequently for fibrin or clot formation and combined with regular laboratory testing to help guide safe adjustments. For the NICU team, anticoagulation management requires continual reassessment. A stable ACT does not guarantee adequate anticoagulation, and clinical findings must be weighed alongside laboratory values. Vigilant monitoring and collaboration with perfusionists and hematology specialists are essential to maintaining this delicate equilibrium. Basic anticoagulation targets only tell part of the story. For safe ECMO support, platelets should be maintained above 100,000 per cubic millimeter and fibrinogen above 150 milligrams per deciliter to reduce bleeding risk. Antithrombin deficiency is common in neonates and can cause apparent heparin resistance. In such cases, supplementation restores heparin efficacy and prevents clot formation in the circuit. Many centers also use thrombolistography or rotational thrombolistometry to provide a global picture of clot strength and lysis, guiding tailored transfusion and anticoagulant dosing. In patients with suspected or confirmed heparin-induced thrombocytopenia, direct thrombin inhibitors such as bivalirudin or argatrobin are viable alternatives. These advanced strategies move anticoagulation from a single-test approach to a multimodal system that balances bleeding and thrombosis with greater precision. Mechanical complications remain a major source of morbidity during ECMO. Oxygenator failure is the most common, often presenting with rising transmembrane pressures and declining gas exchange efficiency. As clot burden builds, oxygen delivery falls and carbon dioxide clearance becomes inadequate, requiring urgent oxygenator exchange. Pump malfunction is less frequent, but immediately dangerous. Centrifugal pump failure, or roller pump malfunction, can abruptly interrupt flow and may also cause hemolysis if the pump head is damaged. Circuit rupture is a catastrophic event that can result in rapid blood loss or air embolism. Although rare, it highlights the importance of redundant equipment and established emergency protocols. Cannula malposition causes inadequate drainage, loss of effective flows, or recirculation of oxygenated blood back into the venous limb. Clinical signs include falling flows, rising venous pressures, or unexplained hypoxemia. Even simple tubing kinks can obstruct flow, especially in small neonates with fragile hemodynamics. Constant circuit surveillance is necessary to prevent these avoidable issues. Management relies on readiness. Backup equipment, trained personnel, and practiced emergency protocols allow teams to respond within seconds. Early recognition of mechanical complications and immediate intervention can mean the difference between safe continuation of support and sudden loss of circulatory stability. Bleeding remains the most frequent complication during neonatal ECMO because systemic anticoagulation is required to keep the circuit functional. Surgical sites are the most obvious source, with oozing from cannulation sites, chest tubes, or sternotomy wounds. Gastrointestinal bleeding can develop from stress ulceration, particularly in critically ill infants. Pulmonary hemorrhage is another concern, especially after cardiac surgery when pulmonary vasculature is already fragile. The most feared site is intracranial bleeding, which carries a high risk of permanent neurologic injury or death. Management begins with careful adjustment of anticoagulation. Minimizing heparin dosing when feasible can reduce bleeding risk, though this must always be balanced against the danger of circuit thrombosis. Platelet transfusions are often necessary because thrombocytopenia develops rapidly on ECMO. Factor replacement helps correct consumptive coagulopathy. When bleeding is severe or localized, surgical intervention may be required to control hemorrhage and stabilize the patient. Daily decision-making requires balancing bleeding against clotting risk. Even small adjustments in anticoagulation parameters can have major consequences, and close surveillance is essential to prevent catastrophic events. Despite continuous anticoagulation, thrombosis remains a major hazard during ECMO. Clot formation within the circuit can occur in the oxygenator, pump head, or tubing. This not only reduces circuit efficiency, but also increases hemolysis and risks embolization. Cerebral thromboembolism is among the most devastating complications. Embolic stroke can present with seizures, altered tone, or coma, and frequently results in long-term neurologic injury. Peripheral cannulation introduces additional risk of limb ischemia. Obstruction from arterial cannulas or distal thrombus can lead to tissue loss if not recognized promptly. Thromboembolism to the kidneys may cause acute kidney injury, further complicating the infant's recovery. Renal perfusion should be closely tracked with urine output and laboratory markers. Prevention relies on adequate anticoagulation and meticulous circuit monitoring. Rising transmembrane pressures or sudden changes in delta pressure often signal thrombus accumulation. Management strategies include intensifying anticoagulation and, when clot burden threatens safety, replacing the affected circuit component. Maintaining the balance between bleeding and clotting is the constant challenge of ECMO. Early recognition of thrombotic complications is vital, as timely intervention can prevent irreversible organ injury or circuit failure. Infection is a frequent complication during ECMO because infants require multiple invasive devices and prolonged critical care. Bloodstream infections are common, often related to central line exposure or direct contamination of the circuit. Cannula sites are another portal of entry, with local infection that can quickly progress to bacteremia or sepsis. Ventilator-associated pneumonia remains a significant concern, particularly when ECMO support prolongs mechanical ventilation. In addition, prolonged support and immune dysregulation create vulnerability to opportunistic infections, including fungal pathogens, which are difficult to eradicate and often severe in neonates. Prevention depends on meticulous sterile technique during all line and circuit manipulations. Many centers adopt antimicrobial prophylaxis protocols, though practices vary. Daily surveillance cultures and careful site inspection are critical for early detection. Management centers on prompt initiation of broad-spectrum antibiotics while awaiting culture data, followed by narrowing therapy when pathogens are identified. Source control is equally important. This may include exchanging infected lines, revising cannulas, or addressing pneumonia with targeted antimicrobial therapy. Because infections add significant morbidity and can be fatal in already fragile infants, vigilance in prevention and aggressive early treatment are essential parts of ECMO care. Multi-organ dysfunction is frequent during ECMO and often determines overall prognosis. Renal injury occurs in up to half of neonates. It develops from hypoperfusion before cannulation, hemolysis within the circuit, and systemic inflammatory activation. Many infants require continuous renal replacement therapy to maintain fluid and electrolyte balance. Hepatic dysfunction is also common. Elevated liver enzymes reflect ischemic injury from low perfusion states. Worsening hepatic function contributes to coagulopathy, which complicates anticoagulation management and increases bleeding risk. Neurologic injury is one of the most feared complications. Intracranial hemorrhage occurs in a significant proportion of neonates and is often catastrophic. Thromboembolic events can cause ischemic stroke with long-term neurodevelopmental sequelae. Seizures may be the first sign of cerebral injury, underscoring the importance of continuous or frequent EEG monitoring. These complications highlight that ECMO, while life-saving, does not eliminate the risks of organ injury. Ongoing surveillance for renal, hepatic, and neurologic dysfunction allows earlier intervention, supports stabilization, and provides critical information for prognosis discussions with families. Successful separation from ECMO depends on recovery of the underlying pathology. The first prerequisite is demonstrable improvement in the disease process that prompted support. Echocardiography plays a central role in confirming adequate native cardiac function, including ventricular contractility and chamber filling. Resolution of pulmonary edema is another important marker, as fluid overload compromises both gas exchange and myocardial performance. Hemodynamic stability must be achieved with minimal inotropic support, showing that the circulation can be maintained without high doses of vasoactive drugs. Gas exchange must also be adequate. The infant should maintain acceptable oxygenation and ventilation at low fractions of inspired oxygen through the ventilator, confirming that the lungs can sustain function independently of extracorporeal support. Finally, the absence of major complications, such as uncontrolled bleeding, stroke, or sepsis, is essential before considering decannulation. Attempting to wean in the presence of ongoing instability exposes the patient to unacceptable risk. At the bedside, structured trials of reduced ECMO flow with close monitoring of perfusion, blood gases, and echocardiography guide the decision to discontinue support. These assessments provide confidence that the infant can transition safely back to native cardiopulmonary function. Weaning from ECMO is a structured and closely monitored process. Readiness should be assessed daily, with emphasis on improvement of the underlying disease and stability on minimal support. Once the criteria are met, the process begins with a gradual reduction of ECMO flows. Flow is decreased incrementally to allow the heart and lungs to assume more of the work while ensuring organ perfusion is maintained. Hemodynamic monitoring during this period is critical. Blood pressure, cardiac output, and peripheral perfusion must remain stable as flows are tapered. Serial echocardiography provides direct assessment of ventricular contractility, chamber filling, and valve competence under the stress of reduced extracorporeal support. Laboratory markers offer additional insight. Rising lactate levels or falling mixed venous saturation suggest inadequate tissue oxygen delivery and signal the need to halt or reverse the trial. Weaning trials are often continued for several hours to fully evaluate tolerance. This extended observation helps identify subtle decompensation that may not appear immediately after flow reduction. By combining clinical monitoring, imaging, and laboratory data, the team can determine whether the infant is ready for safe decannulation or requires additional time on support. A structured protocol provides consistency and safety during ECMO weaning. The first step is to reduce flow by about 25% while maintaining more than half of the original support. This gives the circulation and lungs an opportunity to demonstrate capacity without withdrawing full assistance. The infant is then observed for 2 to 4 hours. This monitoring period allows the team to evaluate whether the heart and lungs can sustain the increased workload over time. During the trial, blood pressure, tissue perfusion, and echocardiographic measures of cardiac function are followed closely. Stability in these parameters supports further flow reduction. If the infant remains stable, the next step is to continue reducing flows incrementally. If instability occurs, such as hypotension, rising lactate, or declining ventricular function, the flow is returned to the prior safe level. The endpoint of the protocol comes when flows are reduced to less than 20 to 30 milliliters per kilogram per minute, with hemodynamics and perfusion maintained. At that point, the patient is considered ready for decannulation. Survival outcomes in neonatal and pediatric cardiac ECMO remain variable and depend heavily on indication and context. For neonates placed on ECMO for cardiac failure, overall survival to hospital discharge is approximately 30 to 50%. Post-operative support following cardiac surgery has slightly better outcomes, with survival ranging from 40 to 60%. Extracorporeal cardiopulmonary resuscitation carries the highest risk, with survival closer to 20 to 40%. In contrast, when ECMO is used as a bridge to heart transplantation, most reports show 60 to 80% successfully supported to transplant. Several factors influence these results. The underlying diagnosis is paramount, as infants with structurally simple but severely dysfunctional hearts often fare better than those with complex malformations. Age and comorbidities also play major roles. Premature infants and those with multi-system disease have lower survival rates. The duration of ECMO support strongly correlates with outcome, with prolonged runs associated with progressive organ injury and worse neurologic recovery. Complications such as bleeding, thrombosis, or infection further reduce the likelihood of survival. Institutional experience is one of the most consistent determinants of success. Centers with higher case volumes and specialized teams report better survival and fewer complications. For this reason, outcomes must always be interpreted within the context of local expertise, patient population, and resources. Survivors of cardiac ECMO often face important long-term challenges that extend well beyond the acute hospitalization. Neurologic outcomes are a major concern. Developmental delays occur in roughly 1/5 to 1/3 of survivors, and seizure disorders are not uncommon. For this reason, structured neurologic and developmental follow-up is essential, including early intervention services and formal neurodevelopmental assessments. Cardiac function remains another area requiring close attention. Many infants have some degree of residual myocardial dysfunction after ECMO, whether from the original disease or from injury sustained during support. These children may require long-term use of inotropes, diuretics, or afterload-reducing agents, and they need regular follow-up with pediatric cardiology to monitor function and adjust therapy. Growth and developmental progress also deserve focus. Feeding difficulties are frequent after prolonged ECMO and critical illness, often related to oromotor weakness, reflux, or neurologic impairment. Despite early setbacks, many children demonstrate catch-up growth over time. Rehabilitation services, including feeding therapy, physical therapy, and occupational therapy, are often necessary to optimize outcomes. Taken together, these long-term considerations highlight the need for comprehensive follow-up that includes neurology, cardiology, and developmental services to support recovery and quality of life. Several high-yield principles guide safe and effective ECMO use in neonates and children with cardiac disease. Early consultation improves outcomes compared with late rescue. Delays allow progression of multi-organ injury, while timely initiation can stabilize physiology before irreversible damage occurs. The therapy requires a team approach. Perfusionists, surgeons, intensivists, and neonatal staff must coordinate continuously, as safe ECMO support is never a single provider task. Daily multidisciplinary rounds create a structured process to evaluate readiness for weaning, monitor for complications, and align treatment plans. Family communication is central. Regular updates on goals, prognosis, and evolving clinical status build trust and help families make informed decisions in a highly stressful setting. Complications are common, including bleeding, thrombosis, infection, and neurologic injury. Constant vigilance is required to detect subtle changes before they escalate. The timing of decannulation is equally critical. Removing support too early risks collapse, while prolonging ECMO unnecessarily increases the burden of complications. Finally, all survivors require long-term follow-up. Ongoing care in neurology, cardiology, and developmental clinics ensures early identification of deficits and timely interventions to optimize long-term quality of life. ECMO is a life-saving intervention for infants with refractory cardiogenic shock or post-operative cardiac failure. It is not a benign therapy, but a high-risk procedure associated with bleeding, thrombosis, infection, and neurologic injury. Its use is confined to centers with specialized expertise and resources because safe management demands constant vigilance and highly trained personnel. Careful patient selection is central to success. Infants with potentially reversible disease or those eligible for transplant or ventricular assist device are the best candidates. In these scenarios, ECMO functions as a bridge, buying time for myocardial recovery, progression to transplantation, or transition to more durable support. Management must be multidisciplinary, involving surgeons, intensivists, perfusionists, and neonatal staff working together to navigate complex physiology and evolving complications. The essential message is that ECMO provides critical support for the sickest cardiac patients, but meaningful outcomes require expert management, thoughtful selection, and an understanding of the significant risks involved.